Good morning, all guys. Oh, God. I'm very happy to be with you with this special skin diseases session. So I'm professor of dermatology in Paris, and I'm very much involved in skin infectious disease. So the purpose of my talk today will be to give you a brief review on my favorite topic, because we only have 15 minutes, and it would have been a challenge to give you what's new in infectious disease. So I decided to focus my talk on two skin diseases. One very rare but life-threatening, and I will tell you why I choose that topic. And the other one is more a public health issue, and it's around scabies. So first, necrotizing soft tissue infection. In the review we just published in the Lancet Infectious Disease in 2023, we highlighted the fact that each of you, at least the doctors, will encounter 2 or 3 cases of NSTI in the career. And you know, for you, it's not that much. But for the people involved, it's a lot, because it's life-threatening, the morbidity is very high, and please, if there is only one message to keep in mind after my talk is think, just think to the disease. And I hope I will be convincing during my talk. Okay, so it's not that rare, because it may occur up to 7 cases per 100,000 per year. As you see in the slide, around 50% of patients have a misdiagnosis initially, and the mortality is still high, up to 30%, with a very significant morbidity around, patient being amputated or with functional sequelas. So just to sum up, it's a disease with high morbidity and major quality of life impact for the people involved, for the patient, and all, you know, the surrounders, the family and the relatives. So as expected, when you know infectious disease, generally speaking, the prevalence and incidence of the disease decreased during the pandemic because of the lockdown, and people wear masks and didn't have contact with the others. But unfortunately, recently, there was a concern worldwide, not only in the UK, in France, in the Netherlands, with the recent emerging increased incidence of the disease. So just, I'm sorry, because I'm a dermatologist and you will see very bad pictures, but making a talk in dermatology without showing pictures, you know, it's impossible for me. So you see here typical features of that necrosis skin infection, and please think to the disease when you have even, you know, just 1 centimeter of such lesion occurring in a patient. So what is important is the fact that it's not that easy to take care of the patients. And we demonstrated some years ago that, at least in France, but it was confirmed elsewhere, we confirmed that centers taking care of at least 3 patients per year, the patients were lucky enough to have a better lifelong, and the mortality was decreasing. Just taking care of 3 patients per year. So showing how important it is to have a center of expertise. So please, the key message is think to the disease and then call a surgeon, because if you call the surgeon, you will save the life of the patient. And so you see what is the surgery is to open, you know, just to shock your memory. You will think to me. Okay. Think to surgery. Okay. Let's move to the other because we just have the, you know, the coffee break and before lunch. So, of course, it's an infectious disease, and you have to deal with antibiotics, but antibiotics will control the shock, will control the septic atmosphere, but will not be able to cure the patient. Again, the only way to cure the patient is surgery. So you have to cover a lot of strains, especially streptococci and staphylococci, using broad-spectrum beta-lactams. And what is important is to add clindamycin. Why clindamycin? Clindamycin has a very good bioavailability on the skin, cover, you know, all the microbes involved in an STI, but what is very important is that recently, relatively recently, this antibiotic showed a very good antitoxinic effect. So you will increase the effect of antibiotics, but be careful, because as usual, when you have a good drug, you use drug extremely largely. And now, at least in the US, resistance to clindamycin began to occur. So be careful with the use of the drug and be focused on the good indication of the drug. So I think you will share with me the key points of this first part of my talk, meaning that you have to think to an STI. Expert center is key in the management of the patient. Think to surgery, of course, add clindamycin, and of course, wound healing is very important once the patient has been operated. So let's move to the second part of my talk, which is scabies. So scabies has been added to the list of neglected tropical disease by the WHO recently, but it's also an increasing issue in high-income country. In low and middle-income countries, there is a true burden with the absenteeism of the children, job absenteeism for the parents, and I will tell you later on what are the potential complications of scabies in those countries. So, facing a patient with scabies, what are the decision-making criteria for choosing treatment? First of all, the type of scabies, because scabies, it's not a unique phenotype skin infectious disease. There are several forms of scabies, especially there are severe forms of scabies called crested scabies, in where there are huge number of mites. On the other hand, classic scabies, the patient usually have 5 to 15 mites on the skin, enough to induce the disease, but moderate form of scabies. The age, the context, are we dealing with individual cases or institutional epidemics or endemicity in low and medium income countries? And regarding the drugs, what are the availability in the countries, the expected compliance, the easy of use, the cost. So just to summarize, you have topical scabicides and you have oral insecticides, antiparasitic drugs, which can be used orally. And in other words, should we choose permethrin 5% applied topically, or benzyl benzoate, which is another topical scabicide, or oral ivermectin? So we made recently a survey all over the world, and I must say that it depends on the habits of the doctors. Some are using oral ivermectin when the drug is available in the countries. Others are using topicals on a practice basis daily. So looking at the evidence, two Cochrane systematic reviews have been performed, but as you see, even if it was, systematic reviews with a theoretically high level of evidence, the conclusions were conflicting. And I liked, this editorial published recently by, a high level, a top level colleague in the evidence-based medicine topic, and there is sometimes subjective interpretation of the medical evidence. And the conclusion of the two Cochrane systematic reviews were absolutely conflicting. On one hand, permethrin is better. On the other hand, oral ivermectin is better. So what to do? So we just finished, and I'm sorry it's a bit frustrating, but I will not give you the results. But we just finished a randomized clinical trial. We are lucky enough in France to be granted, let's say, for academic research by the French Ministry of Health. And we just finished a randomized clinical trial comparing in good conditions oral ivermectin to dosages of standard dose, 200 micrograms per kilo, to topical permethrin applied twice. And what was interesting was that we did a cluster randomized clinical trial, meaning that in the family, in the households of the patients, which should be treated systematically in the scabies topic, we gave exactly the same treatment as the index case. So I think that this randomized clinical trial will give the best evidence available in the topic. So just to give you a new concern regarding the use of topical permethrin, it's only a molecular concern. For the moment, it has not been confirmed from a clinical point of view. But what is interesting is the fact that the mites, they are parasites. And when they are facing for a long time to a topical parasite, they have been able to resist to the neurotoxic effect of the scabicide. And they mutated. And this mutation led to a loss of efficacy, at least at a molecular level, of permethrin. So that is a concern, especially in Austria. Maybe in Italy, there was a short letter showing that sensitivity of permethrin decreased in patients, and we'll see what will be the future. So let's move. I don't know how long I have. Almost finished. So I will go just to say that we just finished French recommendation regarding the use of scabicides in pregnant ladies. And just to say that in France, we are absolutely allowed to use, if we want to, oral ivermectin, which is not the case in the US because it's category C. But we had a lot of experience to use such a drug in pregnant ladies. And we also finished a recommendation regarding the use of scabicides in neonates, in infants. In infants, we should prefer permethrin 5% first, because oral ivermectin is contraindicated in infants and children weighing less than 15 kilos. But of course, if you need to, you could, especially if you send the infants to the hospitals, and the pediatricians will take care of the patient at the second line. So let's move to severe scabies, meaning patients with a huge number of scabies, and it has been clearly demonstrated that severe scabies, especially in the elderly, may lead to mortality because it is associated with infectious complications, with dehydration, with loss of read losses, and finally, increased risk of death. So that is an issue in those patients. So it is important to know what to do. And again, don't be frustrated, but we just finished a randomized clinical trial comparing a combination therapy, oral ivermectin plus permethrin, and we compared two dosages of ivermectin, a high one, a higher dosage, and a lower dosage, and we'll have the final results very soon. So just to say that in low and medium income countries, you know, scabies is associated with a burden, significant burden of the disease, with especially, at least in the Pacific, scabies is associated with post-streptococci complications. And what we thought disappeared, you know, in high-income countries, such as rheumatic fever, cardiac complications, do exist in those regions and should be controlled by good programs of mass drug administration to decrease the level of scabies prevalence. And that was exactly what it has been done with the use of oral ivermectin, and in this meta-analysis, it clearly showed that using oral ivermectin is able to decrease significantly the level of scabies in those countries. So moxidectin will be maybe the future, meaning that you will need only one single intake of the drug, because generally speaking, you have to take 2 intakes of the drugs, because in scabies, the drugs are not able to kill the eggs, only the adults stages of the mites. So maybe that will be the future. So in scabies, what are the key points? Optimizing treatment, either in classic scabies or severe, it's important. And there is a public health issue of scabies in both low and middle income countries and high income countries. And thank you. So we'll have a question-answer session at the end. And so it's my pleasure, really, I mean it, to call Paolo GISONDI. He's professor of dermatology in Verona, and is very much involved in inflammatory skin disease. So Paolo, thank you to be with us today.
Thank you to you. Thank you. Thank you. Grazie, 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 grazie. Buongiorno, good morning, ladies and gentlemen. It's an honor for me to stay with you, and I thank you very much, Oliver, and of course, Galien International Forum for asking my contribution to this prestigious meeting. What's new in inflammatory? The contents of my presentation are 3 stories. 3 stories of patients: Karima, Fiorenzo, and Gina, linked to 3 inflammatory diseases, such as generalized pustular psoriasis, chronic plaque psoriasis severe case, and alopecia areata. And this is an introduction for 3 novel drugs: spesolimab, bimekizumab, and baricitinib. Let's start with Karima. The Karima story: she's from Morocco, age 35, recently moved to Verona. She is separated from the husband with a daughter attending primary school. I met her for the first time in 2009, and the diagnosis was generalized pustular psoriasis, as you can see in the picture. This was the baseline. I perceived Karima difficulties in being the only point of reference for her daughter, in having been left alone, and also having a disabling disease, asking for help. I tried different systemic treatment in order to help Karima during this year. Conventional biological treatment with partial efficacy, partial inefficacy. They lost efficacy over the time. Then I met this publication on spesolimab for generalized pustular psoriasis, the first clinical trial. And this was the first infusion of spesolimab with Karima. She's on the bed because of fever, because malaise, and general different situation. And this is the infusion injection. And this is the baseline of Karima. And please note, after 1 week, and please note, after 2 weeks, complete skin clearance. After the infusion injection, you can see other details of the elbows, and in this case, you can see also the plaque psoriasis. It was associated with pustular psoriasis. It has improved. You can see that Karima is lying forward because of pain on the skin. He was not able to stay like this. And also this situation improved after 1 week. You have other detail of the legs. And Karima is grateful. When she came back to me, she was with tagine and with vegetable and meats. GPP, generalized pustular psoriasis, is a rare autoinflammatory skin disease characterized by widespread sterile pustules, neutrophilic pustule, associated with systemic syndrome and lab abnormalities, and could have also severe complications, including deaths. Is characterized by the flare, and skin symptoms are pain, burning, and pruritus. A breakthrough in the pathogenesis, in the knowledge of the pathogenesis of GPP is the finding, the discovery of a null mutation of IL-30C receptor antagonist loss of function mutation. So the pathway of IL-30C is active and not without inhibition in this disease. And so there is a rationale, important rationale, to contrast these activated pathways. Spesolimab is a humanized monoclonal antibody against IL-30C receptor, and so it blocks the subunit IL-30C alpha, beta, and gamma binding to the receptor, and so we have the inflammatory signaling linked to IL-30C that is attenuated. This is the overview of spesolimab clinical program in GPP. I have not the time to go into detail, but just to focus on the flare treatment, EFISAL-1 trials, and EFISAL-2 is on the maintenance and prevention of flare. This is the week 1, after 1 week. Primary endpoint of EFISAL-1, you can see that more than half of the patient have a complete clearance of pustule after 1 week of the intravascular injection compared to 5% of the placebo. This is the GPP total score of 0.1. So this is, of course, met the primary endpoint of the study. And what happens in the long term to the prevention of the other flare, this is the primary endpoint of a EFISAL-2 trial, time to flare up is reduced compared to placebo, the gray line, if the patient received spesolimab, loading dose 600 milligram, and then 300 ml subcutaneously every 4 weeks. So is effective also in the prevention of the next flares. So spesolimab in GPP helps to achieve sustained resolution of skin and systemic symptoms, to prevent GPP flare, to normalize error-rated quality of life, and not to include safety concern. Second story is Fiorenzo. Fiorenzo, male, 64 years old, came to our attention in December 2022 for severe plaque psoriasis. You can see some detail of the face, but psoriasis was very diffuse. He was depressed, alcohol abuse, heavy smoker, and chronic obstructive pulmonary disease. Listen to the general situation. The patient lives in a house provided by a cooperative she works for, which takes care of the patient's social and medical management. But why this? Fiorenzo was deceived by his previous employers and was given legal blame for the failure of the company he worked for. And his material assets, including the house, were confiscated by the government. I perceived his desperation and sense of helplessness because of financial situation and illness. It was not possible to speak with Fiorenzo because completely without words and without hope. So this is the situation at baseline. You can see that psoriasis affect also the elbows and is particularly thickened, but also the hands. Look at the yellow pigmentation of the nail due to nicotine use for cigarette smoking, and noted how thickened is the skin of the hands. Then came to our attention bimekizumab. This is a trial comparing bimekizumab versus secukinumab. And this is the baseline situation 1 month after bimekizumab, meaning just one injection, because it's a drug administered subcutaneously every 4 weeks, so every month. And you can see after 2 months, he cut the hair. He was used to have long because of covering the face. Also on the scalp, the situation, the improvement, and also on the back, only residual hyperpigmentation of the skin, post-inflammatory hyperpigmentation of the skin, and you can see also some other details of the trunk, of the elbows, the left elbows, and also is quite impressive also on the hands, dorsum of the hands. Psoriasis is a common disease. In contrast to GPP that is rare, psoriasis affects 3% of the general population, and the hallmark of the disease are the plaques, erythematous descalating plaques, usually localized on extensor surface, but sometimes could be widespread. Psoriasis is frequently associated to inflammatory, metabolic, psychological, psychiatric comorbidities, and skin symptoms include pruritus and pain. For years, I have investigated the association with psoriasis with metabolic comorbidities, including obesity, metabolic syndrome, diabetes, non-alcoholic steatohepatosis. Half of patients have liver steatosis, and is related to the inflammation of the skin in some way. The key cytokines playing a role in the immunopathogenesis of psoriasis include TNF, IL-12, IL-23, and IL-17. IL-17 is very potent in the stimulation of keratinocyte proliferation. And bimekizumab is a potent inhibitor of IL-17A and DEF. And the inhibition of the heterodimers A and LEF has a very rapid of action, depth action, and also durable action. Either on the inflammation of the skin, as the case of Fiorenzo, but also on the synovial side, on the joints. These are the head-to-head trial comparing bimekizumab with the other drug for psoriasis, including ustekinumab, adalimumab, and secukinumab, the red one. Secukinumab is a very good drug, but its action is against IL-17A. So just blocking the A, we have 48% of PASI 100 response. Blocking A and F, we have 61%. So it is very convincing of the importance of blocking both the cytokine. The more the action against IL-17, the more is the risk of candida. Generally, candida affect mucosa, or is oral candida, and the proportion is approximately 9 patients per year. 9% of patients per year. The last story, I am on time, right? Yes. Yes, yes. Is Gina. Gina is female, 52 years old, patient Guama, attention for alopecia areata totalis, meaning that the disease affects the scalp, eyelashes, and eyebrows. No comorbidity, Gina is healthy. She works as a journalist in the editorial office of a local television in Verona. Topical therapy, cyclosporine, azatioprine, failed or not tolerated. Gina developed alopecia after a serious motorbike accident involving her son-in-law, father of 2 children aged 3 and 7 years. And this was the baseline situation of Gina. Baricitinib in alopecia areata attracted my attention. This is the phase 2 phase 3 trials for baricitinib in alopecia areata, and I prescribed baricitinib 4 milligram per os to Gina. This is the week 0, this is the week 24, and this is the week 36. It seems another person because with the hair and also tinted hair with the color. Alopecia areata is an immune inflammatory disease characterized by the sudden onset of no-scarring alopecia involving scalp, eyelashes, eyebrow, and body hair. The clinical presentation is very heterogeneous. Could be patchy, could be totalis, like Gina, could be universali, all the body hair. Ophiacy pattern, when the occipital area is involved, could be diffuse. Alopecia areata has a tremendous impact on quality of life of patient and also mental health and productivity, and treatment available now are often ineffective, frequently ineffective, and sometimes toxic for the patient. The diagnosis of alopecia areata is clinically made, but sometimes is supported by dermoscopy, and these are the pattern of dermoscopy, showing you in A, the exclamation point hair, in B, the yellow dots around the follicle, and in C, the short hair, that good sign, because meaning that the hair are regrowing. The SALT is the severity of alopecia areata score that is a gold standard for measuring the severity of alopecia areata. In the pathogenesis of alopecia areata, T-cell mediated cell play a very important role, in particular CD8 positive T-cell and natural killer positive cells. And alopecia areata is accompanied by the marked interferon gamma response and upregulation of cytokine, including IL-15, 2, 7, 21, which activate the JAK-STAT pathway. Baricitinib is an oral JAK inhibitor that block the production of this cytokine. So there is a strong rationale to the effectiveness of baricitinib in alopecia areata. These are the clinical trials, the proportion of patients achieving SALT less than 20, so the primary endpoint of the study, and the red line means the 4 milligram dose. Statistically significant compared to placebo, of course. Baricitinib in alopecia areata, 4 milligram are more effective in primary, secondary endpoint, and patient-reported outcome. Baricitinib treatment is associated with higher rates of acne, urinary tract infection, elevated CPK, and increased LDL, HDL cholesterol. Occurrence of infection possible, MACE malignancy possible, but were low, with no reports of venous thrombosis. And trials are going to assess long-term efficacy and safety of baricitinib in alopecia areata up to long-term. I am arrived to my conclusion. And since we are in Rome, I took this inspiration for you. My belief is that only together we can achieve great results. We are physicians, we are entrepreneurs, we work for industry, we are researchers, in the end we are a human being. My belief is only together. Today we are more connected, particularly remotely, than united. I prefer to be united than connected. We are in Rome, metaphorically. I borrow the words of Generale Massimo Decimo Meridius from the Ridley Scott film Gladiator. Imagine the scene of the film. We are in the arena. He's in the arena. faced with the danger of being attacked by the barbarian horde, and she asked for what?
Anyone here been in the army? Yes. I served with you in Verona. You can help me. Whatever comes out of these gates, we've got a better chance of survival if we work together. Do you understand? If we stay together, we survive.
Thank you. This is my...
Thank you, Paolo, for this amazing talk and conclusion. And you know, it's always for this sort of workshop to have a good opportunity to invite both friends and top leader in the field. And I am very happy to give you the opportunity to give your talk. Professor Celeste LEBBE, she is one of the worldwide leader in Dermatooncology, and she will summarize what is new in this enormous field of dermatology. Thank you. Thank you, thank you.
Thank you very much, Olivier, for these kind words. I'm very honored and happy to be here with you today. Here are my disclosures. So why should we focus on skin cancers? Well, because these include melanoma and what we call non-melanoma skin cancers, which are mostly consisting in squamous cell carcinoma and basal cell carcinoma, as you can see here. These cancers represent the most frequent cancers, if you take into consideration, of course, non-melanoma skin cancers. And what needs to be said is that non-melanoma skin cancers are very frequent, but hopefully less than 10% of them will lead to advanced disease. So I have spared you a few very impressive pictures, because you already had a lot of pictures, I think, today. But I could have made a huge success, I think. Considering melanoma, of course, the frequency is much less. I have highlighted in dark blue here about 25% of melanomas, which are the great killers. Stage very thick melanoma, stage 2B to C, stage 3 melanomas, meaning patients with local regional disease, and stage 4 melanoma, meaning metastatic disease. But you can, so these are the great killers. We have made a lot of improvement. We will come back to that. What about stage 1 and 2A? These are thin melanomas, good prognosis in general, but they are the most frequent melanomas. And they can, however, be responsible for metastatic disease. And in fact, they are responsible for 60% of mortality linked to melanoma, meaning that so far we have focused on 25% of melanomas, but if you want really to change the epidemiology in the future of this disease, we'll have to find something for the 75% others. The incidence of skin cancers is still rising in Europe and many other continents. And I'm glad to say that melanoma mortality tends to decrease in, let's say, young population, and this at least in European countries who have access to innovative treatment, since this is mostly due to these treatments. So what was the treatment of skin cancer until very recently? You can see that from the bottom, primary tumor, local, regional, and metastatic disease. The main actor here were surgeons. And they get people rid of their melanoma by surgery. We had very few efficient adjuvant therapy. And once patient had systemic disease, for a very long time we had no treatment. And since about 15 years, we have had major players in the field. That's the situation now, and in the future, how it's evolving. Surgery remained the standard of care of primary tumor, But going to local regional disease, meaning patients with lymph node involvement, we are more and more talking about perioperative immunotherapy, which is also the standard of care of metastatic disease. And I already touched upon the new players in the field of melanoma, which came out around 10 years ago, so this is very new. On the left, you have targeted therapies, and it's true that in 40 to 50% of melanomas, we have a driver mutation, which is called BRAF V600, mostly V600E, which leads to an increase of the MAP kinase pathway activation. And we have currently 3 combinations of BRAF and MEK inhibitor, very potent on this kind of melanoma. Vemurafenib plus cobimetinib, dabrafenib plus trametinib, and the last but not least combination, encorafenib plus binimetinib. On the other side, on the right side, you have what we call immune checkpoint inhibitors. There are 4 players in the field for us. Anti-CTLA-4, anti-PD-1, anti-PD-L1, and anti-LAG-3. You might view checkpoints as molecules on the T lymphocyte surface, not only T lymphocyte, by the way, particularly for LAG-3, and these are brakes on these cells. Breaks in order to downregulate T cells. If you leave the brake, if you relieve the brake, that will lead, theoretically at least, to T lymphocyte activation. That's exactly the goal. And today, we will review the place of this treatment. I have chosen the focus of melanoma, but there's a lot to be said also in non-melanoma skin cancer. Maybe we will have time in the questions. So let's talk about the management currently of a primary tumor. I told you the surgeon is still the good guy, and we have good candidates for adjuvant immunotherapy for high risk of relapse, stage 2B to C melanoma, meaning melanoma very thick, more than 4 millimeter breast low, or more than 2 breast low with ulceration. So once you have performed surgery, the goal of adjuvant therapy is to give a short time of therapy in order to increase relapse-free survival. And in fact, the real goal should be to increase overall survival. And a good surrogate marker of this is distant metastasis-free survival. What have you achieved in this field? Well, we have now mature results from 2 pivotal trials evaluating anti-PD-1, pembrolizumab or nivolumab, in these thick melanomas without lymph node involvement. And these are very positive. They reduces the risk of relapse by 40 to 50%, which is very highly significant. When you look at the number of patients you need to treat to prevent one recurrence, it's about 8 patients, which seems rather fair. And these good results leads to distant metastasis-free survival benefit, as you can see here, very impressive results, although we are still waiting for the results in terms of overall survival. Of course, there's a price to pay in terms of toxicity. You're probably well aware of the immune-related adverse events. Turning lymphocytes T against the tumor might also result in turning them into normal cells with autoimmunity. And in these adjuvant trials, it was shown that for every 8.7 patients treated with nivolumab, in these cases, 1 patient would have experienced grade 3 or 4 immune-related adverse events. Though there is a price to pay, we have to keep this in mind, of course. Staying in the field of adjuvant treatment for thick melanoma, we have a new player in the field, not yet approved. These are personalized vaccine, or rather called individualized neoantigen therapy. So this is a phase 2 trial which randomized these patients with thick melanoma to receive after surgery either a combination of anti-PD-1 plus this personalized vaccine, either standard of care, pembrolizumab alone, and the results is striking, high benefit in terms of relapse-free survival, and this is also the case in terms of distant metastasis-free survival. And the good thing is that apart from a flu-like syndrome, you do not add any significant toxicity to anti-PD-1. So we are currently accruing patients in the phase 3 trial, but this, I think, will be, you will hear about it in the future. Let's switch now to the management of local regional cancer. Again, in the field of melanoma, so again, I'm talking about patients with lymph nodes mostly. And as I already said, in the past, the surgeon was the only player. Now we are treating patients with surgery and adjuvant immunotherapy, but we are switching to a very original treatment, which is called neoadjuvant or perioperative immunotherapy treatment, meaning that before the patient goes to the surgeon, he receives 1, 2, 3 courses of immunotherapy, he gets surgery, and then currently he still gets adjuvant therapy. But what we are moving to probably, at least for probably 50% of the patients, is immunotherapy alone. And I will just briefly give you a few curves. You got figures with Olivier, you got curves from me. These are the result of the 3 pivotal trials in the field of adjuvant therapy in resected stage 3 melanoma. 1 trial with targeted therapy, and 2 trials with anti-PD-1, Nivo or Pembro, highly significant. And I switch that. But the very important thing maybe to remember here, because this is the future for this kind of patient, are the results of 2 trials, 2 randomized trials using neoadjuvant immunotherapy before surgery. So I give you here the results, which are very new, recently published in the New England Journal of Medicine. I thought melanoma, no, medicine. And discussed at ASCO. So Christian Blank plays a very important role in the field. This guy from the Netherlands was the first one to imagine this kind of treatment and to demonstrate that giving this neoadjuvant treatment allowed patients to develop more new T lymphocyte clones, a larger repertoire of clones, rather than just giving nivolumab after surgery. The American team, just before him, 1 year ago, published results using neoadjuvant pembrolizumab, so anti-PD-1 alone, in the neoadjuvant setting. The results are clear-cut. You see the 2 curves. The blue curve is a Pembro neoadjuvant surgery and then Pembro adjuvant, and the red curve is the standard of care, so surgery plus pembrolizumab. Highly significant. We're waiting for overall survival data, and this is the new data, the NADINA trial from Christian Blank, same population of stage 3 melanoma. The patients are randomized to receive 2 courses of combination of anti-CTLA-4 and anti-PD-1, then surgery, and then according to the pathological response, they receive or not adjuvant therapy. And the control arm received directly surgery, followed by anti-PD-1 adjuvant treatment. And here, look at the results. Primary endpoint is event-free survival, and there is a highly statistically significant difference between the neoadjuvant arm and the red arm. And Christian has shown that the major or complete or near complete pathological response was achieved in up to 60% of patients who were treated with the neoadjuvant arm, meaning, and you can see the relapse-free survival of this category of patients, they are the green curves here, meaning that we could postulate that up to 60% of patients might be cured by only 2 infusions of Ipi-Nivo without the help of any adjuvant therapy. Let's finish by metastatic disease. Again, the example of melanoma. And I summarized here the results of 3 pivotal trials, one with a combination of anti-BRAF MEK. There's another trial with a combination of encorafenib and binimetinib. We will see the results. And 2 pivotal trials with combination of nivolumab and ipilimumab, anti-PD-1 CTLA-4, more recently anti-PD-1, anti-LAG-3, all dedicated to first-line metastatic patients. Look at the results in terms of long-term survival. We have a very long time to follow up. Look for the 68 study with Ipi-Nivo. We have now overall survival rates at 10 years, and we can say that up to 50% of patients treated with the combination arm are alive at 5 years, compared to 6 to 8 months as median survival 10 years ago. Similar results, but not yet so mature with anti-LAG-3 plus anti-BD1, and good results, but not as impressive with targeted therapies, with 5 years overall survival rate of 34%. So the standard of care for the first-line therapy in metastatic disease is a combination of immunotherapy. The problem now is, since we are using more and more these agents, these new agents, earlier in the adjuvant or neoadjuvant setting, what are we going to use for the poor patients who relapse despite this treatment? And we have now, again, our unmet medical need population. We have hopes with maybe T lymphocyte infiltrating the tumors, maybe with new compounds, IMTAC, and you will hear probably this evening about one of these IMTAC, which was a real breakthrough in uveal melanoma. But so far, these are really poor patients, and we have to find something. So in summary, hope I have convinced you that driver oncogenes, which have been identified in melanoma, BRAF, but also I didn't talk about it in other skin cancers, such as SMO inhibitors in the basal cell carcinoma, led to the approval of very potent targeted therapies. But the real revolution came from immune checkpoint inhibition with the combination of anti-PD-1 or anti-PD-L1, not approved in melanoma, but in another skin cancer, and CTLA-4, anti-CTLA-4. It's a standard of care. It's also a standard of care in the adjuvant and probably now in the neoadjuvant tested setting for stage 3. There will be a smaller role for the surgeon in the future, but we will still need you, whoever you are, surgeon in the room. And we have a high need to find therapeutic breakthroughs for immune checkpoint escapes. So I hope I'm in time. Thank you for your attention.
Thank you, Celeste, for your excellent talk on a topic which is still on the rise. We still have around 6-7 minutes for discussion. Any questions? You have a unique opportunity to ask the question to eye leaders, you know. Any question from the floor? Please be enthusiastic. Yes. Yes, just 1 moment. You will have a micro. Give your name, where you coming from.
Is it working?
Not really.
Hello. Now it works. My name is Christopher Henschel. I'm here part of the Cube Labs team here. My question is to do with the immune checkpoint escape, which you mentioned there. And I was wondering how much is known about the mechanisms of that escape.
Oh, the escape to immune checkpoint inhibitors? Well, there have been a lot of publication. I'm sure that there are many other unknown mechanisms, but there are various ways to escape. For instance, you can have what's the so-called cold tumors with no lymphocyte in the tumors for several reasons, very immunosuppressive microenvironments, which is repulsive to these cells. And probably these IMTAC the molecule tebentafusp, so-called bispecific TCR bispecific could be of help to circumvent this. The tumor can also, and this is quite frequent, decide to switch off the expression of MHC class 1 antigens, being totally invisible to the immune system. I was talking about vaccines. I mean, vaccines will have a role, but in case the tumor will decide to mutate again, and there's permanent mutations and develop other neoantigens, this might be also another way to escape. So unfortunately, there's a lot of escape mechanisms.
Any other questions? Yeah, the lady here, please. Can you give the microphone to the lady? Yeah. Thank you.
Hi, thank you very much for your talks. I'm Ida from London. A question to Paolo. There were a lot of triggering factors that led to some of these skin diseases, and the treatments seemed phenomenal in terms of what you presented and the pictures. Were there any combination therapies that went along with that, in particular in the field of mental health? Because a lot of incidents led to their cause of disease, it seemed.
Yes, thank you for the question. Is an important issue, the anxiety and depression symptom associated with all these disease. Most of the data are on psoriasis. And also dependence on alcohol abuse and also from drugs addiction abuse. Is a kind of patient that when you propose the patient to have a psychological consultation, do a step back. Usually do a step back because makes confusion between the skin and the impact of mental health on the skin in the perspective of the patient. However, it's very important when there is a request from the patient. It's very important to react to this request and also to support the patient when possible. And is a trigger, yes. Having received stressful life events, either acute stressful life event and a chronic overload, are risk factor for worsening of the disease in genetic predisposed individuals. Thank you.
Maybe a last question from the floor.
I have one for you. No, I mean, Oliver, a suggestion for you to me, for my practice tomorrow morning. I receive a patient with scabies, and today I usually associate topical permethrin and oral ivermectin to be sure that the treatment is effective. Because with the topical, I always the doubt that the patient does not apply correctly the topical. And so to be more confident, I combine both. Which is your suggestion for me?
From an evidence-based medicine point of view, I would say no. I would restrict the combination therapy to more severe cases because you take the risk of increasing resistance to both our drugs. I may understand that sometimes in some patients, they are reluctant to well apply the local therapy. So discard it, give the oral one. But today, I would say that there is no evidence to support that both treatments are superior to each of one taken separately. But maybe, it's more evidence-based and not enough practice changing, but we'll see in the future. Okay, so it's time to end the session. Thanks to the audience. Thanks, of course, to the speakers. Thanks to the organizers. And I don't know what is, there is a lunchtime, just close to here, I imagine. And then we'll come back this afternoon at One. So please be here on time. Thank you so much.